All right, thank you everyone. I think we'll get started on the first session. It's my honor to be here again to talk about the role of local therapy for oligometastatic and oligoprogressive cancers. And this is my disclosure. So there are several objectives today. We will look at what the mechanisms of radiation therapy that contributes to the management of metastatic cancer, and then look at some evidence associated with clinical trials, as well as identifying new technologies and combination approaches to improve patient outcomes. We will finally have a brief overview of the specialized palliative and oligometastatic radiation clinic. Okay, so we now know that in the past, radiation was probably just used for palliation only. But nowadays, we have the ablative radiotherapy technique to really help us with patients with oligometastatic or other metastatic cancers to help them in each of their stages of cancer management. So radiation itself is no longer just a tool of palliation, but it can be also used to change the treatment as well as the prognosis. All right, so before we start, I want to just clarify a few terminologies. So how do we determine what is oligometastatic disease versus oligoprogression? So for oligometastatic disease, there's no real absolute consensus definition, but typically we count it by numbers, the number of less than or equal to 3 to 5 lesions. We typically say that it's oligometastatic. And for oligoprogression, this term is relatively newer. That means that you can have a lot more sites of disease. So you don't have to be oligometastatic, but you only have very few that are progressing in the background of other stable lesions. So that's the difference. And really the determination of survival of oligometastatic versus oligoprogression, it really hinges on the time of diagnosis, because if you detect those patients earlier, they are going to survive longer. It doesn't mean that they were better prognosis, it's just that you actually catch them early. So we need to be aware of this lead time bias. And as I said, the definition of oligometastatic right now, it bases only on clinical observation. But we don't know if some of the oligometastatic patients, they might be harboring occult lesions that might eventually manifest. So we have to, right now we don't have a great tool to distinguish between the true oligometastatic versus the occult polymetastatic disease. And so I think that's the current challenge of how we define these patients. The ESTRO and ASTRO did come up with a consensus guideline. Again, as I mentioned before, there are some questions here I'll go through. So the number 5 is oligometastatic disease defined by just a maximum number of lesions? No, as I said, the definition is biological. Because of our inability to really define the disease phenomenon doesn't mean that we have to set a minimum number or maximum number of lesions. Right now, I think the possibility of safely deliver curative intent metastasis-directed radiotherapy, I think it determines the maximum number of lesions that we can treat. And then also, is the maximum disease burden defined by technologically safe treatment with curative intent? Yes, but we also want to recognize that the ability to treat safely doesn't mean that you have to treat everything. Okay. Then finally, when is progression under systemic therapy considered oligometastatic? So as I said before, oligoprogression is a newer term that should be used to define oligometastases. There is no consensus whether or not the criteria for number of disease sites or locations should differ. But again, these two are separate, different phenomena. Okay. So I will go through some of the recently published and completed trials. And this table is relatively small, but it lists a recently or in the last decade complete histology-specific oligometastatic disease and oligoprogression trials with reported outcomes. So you can see there, some of these trials are very classic that everyone is probably very aware of, the MD Anderson oligometastatic trial, the TsaiPrincess. So I won't go into the details of these trials. But I do want to highlight some of the newer trials that were either presented and not yet published or just recently been published. So the NRG-BR002, it was a phase 2-3 trial designed in 2 stages and focused just on breast cancer. The patients were either ER positive or ER negative. They were defined, again, interesting, 1 to 4 metastatic lesions. So again, I mentioned before, the definition can be very can vary between trials. So they're defining oligometastatic disease as 1 to 4 mets. These patients were randomized to either standard of care or standard of care plus SBRT. So very disappointingly, when they look at the phase 2 outcome by treatment arm, looking at the progression-free survival, there is no difference between the SBRT or SABR arm versus the standard of care arm. As a result, the study didn't proceed to phase 3. They closed at phase 2. We are still waiting for their final analysis. So here is another oligomet trial that's just been published this year and was presented earlier at ASTRO. This is also breast cancer specific. It's a smaller basket under a bigger trial that's called EXTEND. So basically the EXTEND trial has different disease histology basket. It has pancreas, it has prostate, it has breast. So this analysis focused on just the breast cancer. Again, it's a randomized phase 2 trial. The number of patients there is relatively small, only about 40 patients. And they were randomized, again, to the addition of SBRT versus standard of care. So you can see that in their analysis, again, there is no definite benefit in their primary endpoint, which is progression-free survival. They're exactly similar between the treatment group and the control group. And then when they analyze, other outcomes, the treatment group, the SBRT group, did have a longer duration of staying on the current systemic therapy, but again, it didn't translate to the improved progression-free survival. So this is the second reported negative oligometastatic breast cancer trial. And then we jump into another basket, that's the pancreas basket, okay? So again, I talk about the EXTEND trial being a basket trial. It's randomizing different cancer histologies. So for pancreas cancer, again, very similar design, about 40 patients randomized to SBRT versus plus standard of care versus standard of care alone. And the result was presented at the GI ASCO and also published in JCO last year. You can see there is a dramatic difference between the progression-free survival in the SBRT arm versus the control arm. And I want you to keep this number in mind. The median progression-free survival is 10 months versus 2.5 months, so it's about 4-fold difference with the benefit of SBRT. There was no overall survival benefit, but again, that wasn't the primary endpoint of this trial. There might be a little bit of difference. We don't know yet. The follow-up is still short. So again, this was a positive trial in terms of progression-free survival. Okay, then I want to talk about another recently presented trial, that's the NRG-LU002. It hasn't been published yet, but it was presented at ASCO last year. We know that in other phase 2 trials, the MD Anderson's Daniel Gomez data that showed increased progression-free survival and overall survival with addition of SBRT in lung cancer, and that was a phase 2 single institution. So NRG conducted this phase 3, 2/3 multi-institution trial to specifically look at this matter. They look at, again, local consolidative therapy after a period of systemic therapy. So the patient, it was a larger trial. There were about 120 patients. It was 2-to-1 randomization favoring the local therapy arm. So the patients were, again, all comers of non-small cell lung cancer. It wasn't stratified by marker status or driver mutation. So they had to receive a period of standard of care systemic therapy, whether it be immunotherapy, chemotherapy, and then they had to have stable disease. And then they were randomized 2-to-1 to local therapy, addition of SBRT versus standard of care. And to our disappointment, so if you look at this, okay, most of the patients had immunotherapy. So this is very different from the Taiwanese population where we mostly had the driver mutation patients, right? So you see those patients here, they were mostly non-driver mutation, and then most patients had very limited numbers of metastatic disease, so there were fewer than 3 or 2. Okay. Very interestingly and very surprisingly, there was in this larger trial, there was no benefit of the addition of SBRT in progression-free survival. And there was also no benefit in overall survival. So why? There are some limitations, and I don't have the final analysis or the paper, but for this patient population, remember, I was telling you that these patients, they had to receive a period of systemic therapy, right? So it turned out that some of those patients, they didn't have oligometastatic disease at diagnosis. They were rendered oligometastatic disease by systemic therapy. So maybe at the time of diagnosis, they had 15 sites of metastatic disease, but then after systemic therapy, they had less than 5. So these patients were still eligible to participate in this trial. We don't know if by including those patients, it made the outcome of the trial not as easy to interpret or not. So we'll wait for their final report. Okay. So, and then I will switch gear, talk about oligoprogression. As I said, oligoprogression is less defined, and you can have a patient that began with polymetastatic disease. You can have 10 lesions. And then after a period of systemic therapy, every lesion shrunk. So that's great. But eventually, some lesions, if not all, would progress. So if in some patients the progression was only limited, then we define it as oligoprogression. So for these patients, do you want to continue the same therapy if you only have one progression? I think many doctors will say, we'll just continue. You only have one site that's progression, right? That's progressing. But if you have 2 or 3, you start to wonder, do you want to switch to the second line, or do you want to add radiation? So we started having this curiosity back in early 2010, between 2010 and 2015, we got referred to SBRT, those oligoprogressive lesions. So that formed our basis to want to do more trials. And upon reviewing all the data, especially in non-small cell lung cancer, they were all single-arm retrospective. At the time, there was no randomized trial that was conducted. So we, as well as others, began the effort of randomized clinical trials to study oligoprogression. So in Canada, by Dr. Palma, they have the STOP trial. That's all sites, all histologies. It actually started with just non-small cell lung cancer, but because of a very slow accrual, they open up to all disease histologies. And then at Sloan Kettering, we had the CURB trial. We only included non-small cell lung cancer and breast cancer. And in the UK, the whole trial is even more specific. They only focus on those on first-line TKI and had oligoprogression. So the data is probably most relevant to the Taiwanese patient population. And we don't have the report yet from that trial. And there's another smaller trial in Canada, it's called SUPPRESS. It is also non-small cell lung cancer, but both immune checkpoint inhibitor and TKI. Okay, so I want to talk a little bit about the CURB trial. There was a phase 2 study that we conducted while I was at Memorial Sloan Kettering. Again, as I mentioned, these were patients with non-small cell lung cancer and breast cancer who had oligoprogression with less than or equal to 5 lesions. And they were stratified by whether this is breast cancer or lung cancer, number of lesions, and receptor or mutation status. So whether they are ER positive or whether they are driver mutation positive, and whether they receive immunotherapy or not. So they were randomized to standard of care. When they progress, they can choose to stay on or they can switch. So it's the medical oncologist choice versus SBRT. So it's 1-to-1 randomization. We opened the trial in 2019, so we actually planned the trial for 3 years before opening it. And we opened in 2019, and we enrolled through COVID. The goal was 160 patients, but then at the interim analysis at 106 patients, we closed the trial due to positive result. So we had 106 patients. They were, again, equally randomized to SBRT versus standard of care. There were slightly more non-small cell lung cancer patients than breast cancer. So we separated them, as we stated before in our analysis. Breast and lung were analyzed separately. So you can see this is a third trial, although this is oligoprogression. It's not oligomet. The previous breast trial, the 2 trials were oligomet, right? So this is the oligoprogression trial that showed no benefit of adding SBRT to oligoprogressive breast cancer. And for the lung patient, we saw, again, very interesting. The median progression survival is exactly very similar to that pancreas. It's 10 months versus 2.5 months. So it's a 4-fold difference in the non-small cell lung cancer group in terms of progression-free survival. And again, our study wasn't powered to detect any overall survival benefit. So we didn't see any overall survival benefit. Plus, we allowed the patient to cross over. So once they had further progression after their initial oligoprogression, they were allowed to get SBRT. So this study wasn't designed to look at overall survival. But as I said, the time to initiation of new systemic therapy, again, it differed from the breast and lung group. The lung group certainly was benefited more by the addition of SBRT that prolonged the mileage of their current systemic therapy duration. Another unique aspect of the trial is that we actually look at the circulating ctDNA. We didn't have that many patients because we enrolled through COVID, so a lot of the visits were virtual. We didn't have the blood sample. But of those about half of the patients that we had blood sample for, we had a baseline blood sample and we had post-SBRT or post-nothing after randomization. So very interesting. If we look at the first 2 columns, the breast cancer, okay, you have the SBRT versus no SBRT, and then you look at the figure, the lines just indicates that whether the level of the ctDNA goes up or down for each individual. So you can see that the changes are just all over the place. You have some levels going up and down, and the SBRT or no SBRT doesn't really distinguish them. But if you look at the non-small cell lung cancer, and if you look at those without SBRT, most patients, so the third graph, the most columns go up, indicating there's still gradual increase of the tumor burden over time. Whereas in the SBRT group, you see most of them go down. So that correlates with the progression-free survival clinically in the cohort. Okay. So I really want to talk about STOP trial because also that's very important, although it's not a positive trial. Again, STOP trial, it was almost exactly the similar design because when I did my CURB trial, the STOP trial was already ongoing. So I was discussing with David Palma that, we should make the studies very similar so that we can pool our data together. So my design was, because his was the first one, it was almost identical. But initially, it was only non-small cell lung cancer only. But then because of very slow accrual, I mentioned they opened to all different histologies. But other definitions are exactly the same as the CURB trial, except that I think it's a 1-to-2 randomization, okay? They didn't see any difference. So the trial was negative. There was no difference between the SABR or SBRT versus the control in terms of progression-free survival or overall survival. So why is that? I think this brings up a lot of trial design considerations. Where do we go from here? Okay. There are, some concerns whether the next studies, do we want to do just single-arm prospective trial? I think there is definitely utility of a single-arm, more refined prospective trials. But I think for the single-arm trials, you want to collect more biology data, more imaging data, other information that you wouldn't otherwise been able to collect in the larger multi-institution or international trials. So I think the prospective single-arm trials are great for studying very selected, very well-defined population, as example outlined here. For the randomized phase 2 to 3 trials, again, do you want to do single histology? Like you want to do just breast or just lung? I think that's ideal if that's possible because as I've shown you before, in the CURB trial, we had breast and lung combined. But then if you look at those separate histologies analyzed separately, you see they're totally responding in very different ways. So ideally, if you have the number of samples and patients, ideally you do want to do a single histology study. But however, in some other situations like the STOP trial, they couldn't accrue. They had to open up to mixed histologies. So it's also a very practical consideration. So you have the STOP trial, you have SABR Comet, and then the SABR Comet 10 is ongoing. It's up to 10 lesions that we are doing now. So I think it's very practical, but if you do detect a signal, say, for example, you have the SABR Comet trial, that's how everyone knows. So you have 10 or 11 different tumors in those 99 patients. All you can infer from that trial is that SBRT can be helpful for some patients, but whether it's helpful for cervical cancer, there's 1 patient or 2 patients there, you cannot really infer that. So I think that's great for looking at a signal, but if you really want to define it further, you need to nail it down to a specific histology, whether it's a single arm or randomized. The basket trial is kind of a compromise in between. You have different basket. Basically, it's similar to the CURB trial. You have the breast cancer and non-small cell lung cancer, but each basket has a very small number, right? So it's good to, again, to look at signals in the different basket, but ultimately you want a larger trial. Okay, so what about endpoints? For radiation trials, do we care only about progression-free survival? I think most of our radiation oncologists care about progression-free survival. But if you take the same trial to medical oncology, they will insist on having overall survival as the endpoint. So I think overall survival is, as an endpoint, is only valid if what you are treating actually is a vital organ that can be lethal if there's progression. So say if you treat the breast metastasis in the bone and other places, you may never get overall survival benefit because those areas, they don't typically directly cause mortality. So I think it's important to keep in mind about the progression-free survival versus overall survival benefit. In the secondary endpoints, I think it's more straightforward. You have toxicities and time to changing the systemic therapy or other biomarkers. Okay. So something that's very exciting is that after the publication of the CURB trial, now we have a CURB 2. As I mentioned before, the CURB trial only detected signals in non-small cell lung cancer that showed progression-free survival. And what's the next step? I think the next step will logically be a larger phase 3 trial. So that's the CURB 2. And after moving to Canada, after completion of the CURB trial, I work with the Canadian Cancer Trialist Group. That's the US counterpart of NRG. So we proposed the CURB 2 trial with the Canadian colleagues and also submitted a proposal to the US. So it was just approved by the US National Cancer Institute Protocol Review Committee and the CTAP. So this trial will be activated in April next month and will be accrued in Canada and in the US through NRG and also potentially internationally, just like what you would with any NRG trial. So that's very exciting. This trial, again, took 2 years to plan after I arrived at Princess Margaret, because then how do we really define this population? As I said, for my non-small cell lung cancer subgroup, it was a mixture of TKI versus immunotherapy, predominantly immunotherapy. So we then defined it that, okay, we just want to look at the immunotherapy group because the TKI population, there is another trial in Europe, as I said, it's ongoing, so we don't want to kind of overlap. So for the CURB 2, we only focus on immune checkpoint inhibitor. So it's immunotherapy plus minus chemotherapy. So they have to be that's first line, and then they have to be stable for at least 3 cycles, and with oligoprogression, again, they'll be randomized to very similar SBRT versus no SBRT, and they'll be followed. So there will be 320 patients and will be accrued internationally. So very exciting. As I said, what's the objectives? Progression-free survival or overall survival? That's why it took almost 2 years to decide, because as I said, for radiation oncologists, we want the progression-free survival, but then when we take it to medical oncology, they say they want overall survival. So we actually compromised. We have a dual primary endpoint with a more complicated calculation. We'll look at both progression-free survival and overall survival as a dual primary endpoint, and there'll be a bunch of other similar secondary objectives. Okay. Then, concurrently, as I said, there are some studies that's probably better conducted in single institution. Like you want to collect serial blood markers, you can't really do that in a large group. So concurrently, we are doing another ctDNA-guided SBRT, that's single arm at Princess Margaret, and I had one of my fellow lead this study. So this will focus on the TKI population because of the biomarker detection. So for example, if you have a non-small cell lung cancer patient that, that has a driver mutation positive and they're on first-line TKI, then after some time, they develop progression. You measure the blood again or you biopsy, then many times it shows a new resistant mutation, right? So if that's the case, and you assume that the new mutation occurred in the progression, in the progressed tumor area, then if you give SBRT, that new mutation should go down. So that's the basis of this single-arm trial. So for these patients that progressed and had a baseline detectable ctDNA, we will all give them SBRT, and then at 4 weeks, you measure the ctDNA again. If that mutation became not detectable, great, you just continue on the same TKI. But if that new mutation persisted even after SBRT, that means there were other hidden tumors mutated you didn't eradicate. So then you ought to switch. So this will guide the patient to whether stay on or switch before their next scan, because usually you scan every 3 months or more. But before then, you should have some signal in the ctDNA. So that's a single-arm study. It's going to be, it's written by one of our fellows. Okay. Another one is also going to be led by one of our fellows is melanoma. Okay, I don't know how many melanoma patients we see here. At Princess Margaret, we have quite a few. And melanoma is usually a disease site that we rarely see in radiation. Luckily, we actually see a lot in Canada. For whatever reason, they send those patients for SBRT for oligoprogression. Remember, the first abscopal effect of radiation was observed in melanoma, and it probably only existed, if ever exists, probably in those neuroendocrine tumors, because it never been proven in other disease sites. So we are very interested because we treated a lot of melanomas, and we found that even melanoma is very radio-resistant. They don't actually need to be treated with high dose in this setting. You don't need a lot of different doses for the melanoma. So in any case, we devised this, again, single-arm trial in melanoma, and we'll stratify on the BRAF mutation status. They will all get SBRT, and we'll measure their ctDNA, and we'll do standard imaging. So it's a single-arm, smaller study, but hopefully we can see some more biology with this. Again, this is led by one of our fellows. Okay, so moving on to practical considerations. As a radiation oncologist, our role is no longer restricted to just knowing our radiation techniques, right? Because there are all these molecular targeted therapies that are being invented every day. And at some point, we are going to face this challenge of combining those therapies with radiation, and many times very high dose radiation. So how do we do that? They usually, for any new drug, there's no data on the safety. So this is just a table that I like to keep it by my side, because there are all these different inhibitors. There will, in addition, so there's small target, small molecule inhibitors, and also targeted therapies, and their mechanisms. So as radiation oncologists, I believe that we have to be very familiar with these, so that we can have a very in-depth conversation with our medical oncologists when we treat those patients. There are many papers that are being published or reviews looking at how do we safely combine radiation, especially SBRT, with these newer targeted agents that usually we don't even know about their safety data. So again, these are reviews, and they are not always, there's not always a randomized trial based on this. But I think it's very helpful to look at half cycles of these. I know the tables are very small. So if you look at them by their categories, and you look at your metabolic rate. So I think you consider them as a half cycles of each drug. And these are the consensus of the experts on that review paper. For example, you see the top left, the immunotherapies are all green, meaning that people generally feel safe of doing radiation concurrently or just withholding for a very short period of time with immunotherapy. And then if you move on to, other anti-angiogenic drugs, then you have to be very cautious. So this table does a very nice job summarizing each individual's comfort level rather than evidence, because there's really no hard evidence. So you can kind of refer to this as their comfort level and decide how many days you want to hold a certain drug while giving SBRT. So as a general suggested approach, one of our previous fellows reviewed different classes of drugs and then came up with some suggestions of days of break between the systemic therapy and radiation therapy. So I think this is also a very useful table to refer to. It's published in Advances. It's open access, so you don't have to have subscription to have the table. All right. So other words of caution, the prior lines of systemic therapy is really important because when the patients go to you, they might have had 5 different lines of systemic therapies. So then you have the radiation recall, just as when you give radiation to breast cancer patients, you're worried about adriamycin and you're worried about chest radiation. So with those newer drugs, you're especially worried about all these different combinations of targeted therapy and the radiation recall. So I think that's very important to consider that, keep that in mind, especially since, say, many of us are very focused on specific disease sites. Say, if I am a thoracic expert, my inclination would be to give the highest dose SBRT to everyone. Say, if a single lesion, small one, I want to give 34 gray in 1 fraction. But keep in mind, that's only in the definitive setting, in the oligomet, without a lot of prior treatment. But for these patients, some other patients, you may want to dial it down, even if you feel that you really want to give very high dose, right? Because you can't know without certainty what the side effects are. So again, we need to be cautious and we need future prospective trials, okay? There are some fun cases I just want to throw in. These are very extreme cases that we treat in our metastatic program. So this was actually head and neck cancer patient with X-pleomorphic adenoma of the right parotid gland. So had the parotidectomy, head and neck adjuvant radiation, very standard in 2013. And then 10 years later, developed this metastatic disease, refractive to all sorts of systemic therapy. So when the patient came to our service, she had undergone 20 gray in 5 fractions to the right lung palliatively, and then 40 gray in 5 fractions to paraspinal med. And the patient was off any systemic therapy because nothing worked. So she came to us with this. So in reviewing all of her prior treatments, we knew that we couldn't give her another 20 gray in 5 fraction because it didn't work. Even the 40 gray in 5 fraction to that paraspinal disease, that continued to progress to occupy the whole lung. So we resorted to the spatially fractionated radiation therapy. I think it looks a lot like brachy. So basically, if you look at the plan, the blue spots are the 20 gray in 5 fraction spots. And the red spots are the hot spots that are 66.7 gray in 5 fractions. So you have those super hot spots interdigited in your background of 20 gray in 5. And you set those constraints to your diaphragm, your chest wall, that all within your tolerant level. So that was the last resort because we don't have anything to offer to the patient. We don't have long follow-up of this patient, but Yeah, but it's very nice that after 2.5 months, and actually we have a 5 months follow-up, it looked a little similar. It regressed a little, not too much, and we didn't anticipate it would regress a lot. But this was some extreme cases that we treat in our metastatic service. There's another case that's non-small cell lung cancer without driver mutation, had initial oligometastatic disease, was treated to bilateral adrenal glands with SBRT on chemoimmunotherapy, then maintenance immunotherapy, and then progressed on prior bilateral SBRT. Again, the patient is elderly. He didn't want to just switch to cytotoxic chemo. He wanted to continue on the immunotherapy, but the adrenal glands, actually the right side progressed more than left. So then we saw this patient. I think he previously had 40 gray in 5 fraction to one side and 35 gray in 5 fraction to the other. So there were pretty good dose of SBRT, and the bowel tolerance probably maxed out. So again, we offered this patient spatially fractionated radiation therapy because there's nothing else we could do. We don't want to give another 20 gray in 5 because I know that wouldn't work. Word of caution, because you look at this adrenal gland, it's right sitting, the tumor invaded to the kidney parenchyma, right? So before giving this radiation, I actually sent this patient to urology to have a stent, because we have seen urinary tract obstruction from fibrosis after SBRT to the kidney. So he had a stent placed in. You can see the stent right there in the bright area. The patient so had a baseline. You can see on the left side, it went into the kidney parenchyma. Then 2 months and 5 months, it started to gradually reduce. And again, this is the cross-sectional view. You can see on the upper pole of the kidney, on the left side, the baseline went into the kidney, and then 2 months is better. At 5 months, it's a lot better. So the patient is still not, so this was an extreme case of oligoprogression on the previously treated adrenal gland. The patient is still on the same immunotherapy and doing well as of now, 5 months. So at least I think this treatment provided additional about 6 months progression-free survival. And we'll see what the long-term follow-up is. Okay, so the final couple minutes, I just want to talk about our dedicated palliative radiotherapy and oligometastatic program. So the program initially at Princess Margaret, it was initially established in 1997, was strictly palliative program because patients were waiting for too long. You want to get palliation right away. So that was the central goal of the care. You see the patient, you get simulated, you treat the same day. So that was the first and #1 goal, is provide patient-centered care. But over time, it evolves, right? Because as I said, radiation is no longer just palliative. It can prevent progression. It can maybe even improve survival. So it kind of evolved into palliative and oligometastatic program. For the palliative side, we further improve our delivery to the fast track, meaning that the patient comes into consultation, they get simulated right after consultation, the plan is planned within an hour, and the patient is treated. For SBRT, we collaborate with other disease sites, but we are able to deliver SBRT the next day. Okay. My goal is to actually do the same day, so we're still working on it. So if you have IMRT or VMAT, we could deliver potentially the same day or the next day. SBRT is the next day. So it evolved into a very fast patient-centered service. In addition to that, as I said, radiation oncology is not only in the siloed basement. We need to know medical oncology, what they are up to, all their latest trial, and also we work with other disciplines. So these are some of other innovations and collaborations that we do. We work with palliative, they are very small. Okay, you guys can see. So we work and we work with physiatry, so that's rehab, for exercise. For example, many patients, because we're treating younger patients with oligomet, for example. So patients come in and say, hey, after my radiation, can I go to the gym? We don't have a great answer, right? Because we say, yeah, you can exercise per your tolerance. But we don't know how much exercise is beneficial and how much is harmful. So we have a trial conducted by one of our junior faculties to work with physiatry to enroll those patients in a very regimented exercise program. First, we want to see we don't do any harm. It doesn't increase their pain level. So that's number one goal. And second, does it improve their function? So that's a very practical study that we collaborated. And again, education, we are doing a lot of videos to tell patients what the trials are, because many patients don't know what randomized clinical trials are. When they come in, they are very hesitant. So we have many of the junior faculty and fellows-led smaller trials that they can complete during their, I think 15 minutes, or 5 minutes, okay. 5 minutes, all right. During their fellowship, and that's the goal. All the fellows, they come in, they have to run a trial. So they have to write a trial, they need to be productive, and they need to write a practical trial. It's not a phase 2 or 3 because you can't get it done, but they should be able to get out of it. So all of our trials, they were either doing education trial or collaborative trials or the single-arm oligoprogression trials, as I mentioned. They were led by 2 fellows, okay? Go through very quickly, we're running out of time. The single fraction SBRT, same day, simulation free, that's our next project. You come in with the consultation. Everything is pre-planned using their diagnostic scan or on ethos that has same-day planning, and then we do same-day single fraction SBRT to the bone. So our single fraction SBRT dose is somewhere between 12 gray to 20 gray in one single fraction. So the goal is to have the patient come in, and they don't have to, wait. They get put on the treatment table right away and get a SBRT and go home, okay? I think I'm running out of time, but we did our dosimetrist and physics, they did a lot of calibration, look at the centered uncertainty of the setup. And this is the exercise trial that's currently open by one of our junior faculty members looking at the bone med patients enrolling in a very regimented exercise program. We have another resident looking at AI prediction for airway obstruction. I think I don't have time to go through that, but very briefly, when you have the patients that come in for airway obstruction, for palliation, we found that it's almost always too late because you give them radiation, their airway might still be collapsed, and that's it for them. So our goal is to work with the computational biologists to actually identify those that are about to obstruct but not yet obstruct, so then we can identify them and then prevent, give them intervention, either radiation or stent, so they never have to present to the ER or being treated on call urgently with not a lot of efficacy. So that's one of the goals. Again, I mentioned the education is key. All the fellows come from all over the place, and I would love to have some fellows from Taiwan to do research with us and see patients. Thank you. Questions? I think we have 1 minute.
Let's listen to the Mandarin. One. One.
Thank you.
Sorry, I have a question.
Huh?
I have a question.
Sorry.
我是张荣杰，应该大家都认识我，从林口长庚医院。那这边应该有很多 junior faculty， 我非常 highly recommend 所有 junior faculty have the chance go to the Toronto。我想蔡医师绝对是一个 very good mentor， 对，去做个1年的训练。那我觉得不一定要学粒子，我就光他学他的 program。然后如果你大家没像他们厉害有 Lancet 的 paper， 但是如果你有 Lancet 看下去，你也够厉害了。我会觉得去他那边绝对是 good choice。对 ，compared to the as I know 的对，讲楼下 M 开头的或 M 开头2家医院呢，我觉得去 T 开头的绝对不会比去 M 开头的在北美来的差。
谢谢。
好，我想我特别来这里是想问的问题啊，因为我知道 oligoprogression 跟 oligometa 是 different story。那在我们放射肿瘤科，大概几乎因为都是在 make on 的后面，所以我们几乎都是治疗 oligoprogression。对，但是以现在我们的技术经验。SBRT 要做个10颗，我想应该没有什么。像你刚刚最后那一张，我觉得你蛮赶的，因为如果是我的光治疗，应该还没有 collapse 就 edema 啦，不会吗？你们现在做到不会？就是obstruction 那个。
你说哪一个
？trachea obstruction 那个。
哦 ，trachea 对，那个就是你，因为一开始你通常他们已经有 obstruction 的话，你用 palliative radiation 根本没有什么用 ，right？ 20 gray in 5 fraction。所以通常都会先 put in stent and then give radiation。But many times it's already too late, so that's why we want them to get treated early before they have symptoms.
但是你其实 early 你会 edema， 你会 radiation induce edema， 你会反而让它更肿，不会吗？你现在
I think it depends. 我们 identify some cases， 那个 pulmonologist 先 stent and then we treat, so that's better. Yes.
好，所以我要问你的是说，我们如果假设有病人在手上，我们可不可以写一个 try， 是说我们就不要等到 oligoprogression。In the beginning， 像有些 case 这样，我就直接做 SBRT oligo， 然后 combine with ICI 啊 chemo 啊，会不会有 promising 的更好的
？It's very possible. I think it's very. And then 你们可以 easily 做在 single arm， 然后 collect data， 对。
所以你会建议说 RT 的医生可以把它把 oligoprogram push 到 oligometa， 就 initially。
对。
那会有没有什么 risk？ 要考虑的？
我觉得就是说，因为你们平常现在已经就在做了嘛，你们只是没有 collect 那个 data， 所以我觉得那个 data collection it's very important， 所以你们可以知道他们的 side effect， 因为你那些病人如果没有仔细的 follow， 你有时候会不晓得他们的 side effect， 所以这样子就算是 single arm 也是很重要，对。
所以你会建议不要等到 oligometa 的时候就
也是可以，但是我觉得那 separate， 因为有一些人他根本不会看到那些病人，直到 oligoprogression 为止，因为那些人刚被 diagnosed， 他不会 refer 给你，对。
台湾会，因为台湾
会，那 that's great。
像我们病人自己治疗完，我们自己 follow， 所以反而很多 recurrent 的是不少是 RT 医生发现的。
对，那 that's great， 对，你可以，对。
All right, we do it. Sorry，
这位有一问题。
Sorry。
对。谢谢蔡教授精彩演讲。那我用中文提。
讲中文多好。
就是像有 gross tumor 的时候，我们会很 comfortable 给 SBRT。那我想请问，像一些 high risk for recurrent like sarcoma, high grade sarcoma， 它的 tumor bed， 那这种状况之下，在比如说 R1 resection， 那适不适合就是用 SBRT， 就是比较 extreme high dose， 像你35、40 grade in 5 fraction 这样子的剂量？
所以就是 microscopic disease R1 sarcoma， 有这个 protocol， 就是hypofractionated radiation， 但是那个 dose 如果是 retroperitoneal， 你就要担心那个 OARs， 对不对？所以我知道的 sarcoma group 有这种 protocol，but I think you probably 你要大概是最好 treat on protocol， 所以可以 follow patients。Thank you.